cardiomyopathy and myocarditis, as you know now, is very talking about reason for the SARS infection is connected with heart disturbances, and after that also with myocarditis. First of all, we discuss the cardiomyopathy. And the cardiomyopathy are a group of diseases that primarily affect the heart muscle and are not a result of congenital acquired valvular hypertensive coronary artery disease or pericardial abnormalities. And this term is restricted only to conditions which primarily affect the myocardium. And this is a very, very heterogeneous group of the myocardium diseases, which may be due to mechanical or electrical dysfunction, and maybe have ventricular hypertrophy in hypertrophic cardiomyopathy or dilatation due to a variety of causes that frequently are also and genetic, and in nowadays have a lot of genetics tests, but these diseases have a lot of mutations of the genes, and it's not easy to discuss that reason, and in many cases may be idiopathic, but if you have family history, is obligatory to discuss genetic tests about that diseases. And from other side, they may be part of generalized systemic disorders, and especially dilated cardiomyopathy, hypertrophic, if not treated, if not stopped, the reason can lead to cardiovascular death or progressive heart failure. So the classification of the cardiomyopathy from one side be according structural changes: hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and the other unclassified or idiopathic. This is the restrictive cardiomyopathy, and they all have their different hemodynamics, different echocardiography changes, but in most of them, especially in dilative, one discuss the etiology, must do biopsy to see the etiology, in many cases viral genome in the biopsy. And so the cardiomyopathy can be familial or genetic or non-genetic or secondary, and that's why it's very difficult in some cases to put the diagnosis. And according to anatomy changes, dilated cardiomyopathy is characterized with enlarged left ventricle camera, left ventricle, and systolic dysfunction. Ejection fraction is low, the pump function is impaired. In hypertrophic cardiomyopathy, the pump function is reserved in the beginning, but the septum or the wall of the left ventricle is thick, and that all lead to diastolic dysfunction. The ejection fraction is normal. In the restrictive cardiomyopathy, have no-so dilatation, no-so hypertrophy, have enlarged atriums left and right, and we have disturbances in the filling of the ventricle, maybe have different hemodynamic changes, and these are rare or most often secondary. The golden reason is the amyloidosis secondary form. Arrhythmogenic right ventricle dysplasia is also genetic or familial form, where we have fibrofatty replacement of the normal structure of the right ventricle, and also some other forms with structural changes of the myocardial fibril in left ventricle non-compaction cardiomyopathy. So the two different big forms are primary and secondary. In the primary is involving the myocardium in the disease of unknown causes, and in secondary the cardiomyopathy is a part of the other systemic disease or toxic intoxication, as chronic alcohol abuse, amyloidosis. Even today, accepted one patient 56 year with alcohol cardiomyopathy with ejection fraction 24, and with atrial flutter atrial fibrillation every night with breathless nocturnal dyspnea and not so big effect from the diuretic therapy. From other side, the risk of as dilated cardiomyopathy for sudden death because every hypertrophy, every dilatation and structural changes are substrate for arrhythmia, and that's why these patients are in risk for sudden death. In etiology classification, they may be idiopathic, maybe endomyocardial fibrosis, or familial. Secondary myocardial involvement in cardiomyopathy, first of all, are the reason is the viral myocarditis, fungal myocarditis, bacterial myocarditis. In the metabolic diseases, familial storage disease, glycogen storage disease, Fabry disease, when it's also a combination from with renal insufficiency, some changes in the neurologic status, or and also ophthalmology, and also genetic disease. In some deficiency conditions, connective tissue disease, more rare, but may be given, especially in dermatomyositis, and lupus gives the picture of myocarditis. In other neuromuscular disease, muscular dystrophy, myotonic dystrophy are also cardiomyopathy in the algorithm of the diagnosis of this neuromuscular disease. The functional classification is dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive or infiltrative cardiomyopathy, and arrhythmogenic right ventricle cardiomyopathy. And in dilated cardiomyopathy, the typical is left or right ventricle enlargement, congestive cardiac failure, arrhythmias, embolic incidents of the enlarged ventricle size or atrial size, but the base is impaired systolic function. In restrictive cardiomyopathy, have myocardial infiltration, which lead to restriction to the left and right ventricular filling. In hypertrophic cardiomyopathy, have different degree, but not due to hypertension or aortic stenosis of left ventricle hypertrophy, typically involve the septum more than 3 or with and without interventricular systolic pressure gradient, and usually the sizes of the left ventricle, right ventricle is normal. What is typical for dilated cardiomyopathy? Most often cardiomyopathy, enlarged left ventricle with decreased systolic function as measured by left ventricle ejection fraction. Systolic failure is marked, and of course in every heart failure happens systolic dysfunction, but in the beginning, and diastolic dysfunction. About one of the 3 cases of the heart failure is due to dilated cardiomyopathy, and most of the cases are of unknown etiology and are idiopathic, but in most cases there may be viral myocarditis, which has healed, but the patient begin to have some symptoms of heart failure and then begin to look for cardiology consultation, and on echocardiography EC ejection low ejection fraction and enlarged left ventricle sizes and the symptoms of the heart failure. So all these patients must be investigated non-invasively and invasively to early to stop the progress of heart failure if have some really as in ischemic cardiomyopathy, as revascularization of the coronary artery disease, and after that can improve the prognosis, can improve the ejection fraction, and so the 3 vessel disease in nowadays in coronary artery disease is indicated, especially in the cases with affection of left anterior coronary artery, and also another for full revascularization that also in these cases can help to improve the systolic function of the patient, improve his prognosis. So the secondary causes for dilated cardiomyopathy are ischemic kinesis in the patient with previous myocardial infarction, not revascularized, and with a big scar on myocardium, which lead to remodeling of the left ventricle and to left systolic dysfunction. Alcoholic cardiomyopathy in the patient who have systemic alcohol abuse many years, and these patients as asked very often how many they drink, not the same, the true amount of alcohol. They say in the women, of course, the amount is very, very small because the alcoholic dehydrogenase enzymes are different in the So must ask about that reason, and it's very often, especially when the patient has intact coronary artery. Peripartum cardiomyopathy. These women during the last trimester, even before 2 days, looking one patient who was in gynecology accepted is she has peripartum cardiomyopathy. They are in the last trimester or first week, first month after delivery, and post-infectious or viral are the most often reason for the cardiomyopathy. So must looking for viral agents, but it's very very difficult, even with phenotypization, even in with nowadays with the test, the diagnosis is most proven on biopsy material for looking for viral agents in the myocardial biopsy, and also the etiology maybe in first time Coxsackie virus, adenovirus, hepatitis C also, and HIV virus. Every virus but Coxsackie adenovirus are the most often. Some parasitic agents give especially Chagas disease, toxoplasmosis, mycoplasma, some rickettsia infection, fever can give also myocarditis and fungal myocarditis on the phone of systemic infection. In the dilated cardiomyopathy secondary forms maybe have different structural changes. Giant cell myocarditis in polymyositis, dermatomyositis, different form of infiltration of the lymphocyte, also, and peripartum cardiomyopathy, and reaction of rejection of transplantant is also proof with biopsy. So, as you can see on this picture, the normal heart and twice enlarged of the left ventricle and also and right ventricle. They are nearly normal size, and the right ventricle is small, but he has the same pump parameters as left ventricle. In third of the quarter of the patients can receive spontaneous recovery, and in other maybe fulminant, and finish with sudden cardiac death or progressive heart failure. So maybe discuss, of course, in young people, mutation in more than 20 genes transmitted in autosomal dominant fashion, who encoded sarcomeric proteins as alpha cardiac actin beta and alpha mucin. These are all elements of the structure of the myofibro and can be disrupted with myosin, troponin, T complex is also myosin complex. What is the clinical picture? The reason for heart failure, different degree. The symptoms may be gradual in onset or have acute presentation with pulmonary edema, with breathlessness, nocturnal cardiac asthma, with arrhythmia, ventricular tachycardia, or sudden death. Also, maybe have on the investigations X-ray, pulmonary congestion, dyspnea at rest, exertional or nocturnal, systemic congestion with appearance of edema of the leg, abdominal pain, and nocturnal in heart failure, the signs of the low cardiac output. The patient maybe have hypertension, have tachycardia, have tachypnea, elevated uvular venous pressure, or as you're looking on the neck, the veins, and also low blood pressure. Very little fatigue and weakness. You must ask on what distance he receive tiredness, must stop to have a little relax and then continue. Different arrhythmia, maybe atrial fibrillation, conduction delays, or complex ventricle and supraventricle extrabeat. The diagnosis is with X-ray, but X-ray cannot give you the diagnosis as echocardiography. The X-ray maybe give enlarged heart shadow, maybe give signs of congestion. You can see the enlarged hues, lines of Kerley B in the base, some different forms of little pleural effusion as congestion. ACG maybe give some rhythm disturbances, tachycardia, AV block, left bundle branch block. Very often, left bundle branch block is in combination with alcoholic cardiomyopathy or idiopathic viral cardiomyopathy. Some different aesthetic changes due to tachycardia, due to some ischemia, because every hypotonia, every tachycardia maybe induce some ischemic changes, and of course must perform 24-hour Holter monitoring and record if the patient have some episode of syncope, where can discuss AV block, different degree, some palpitation, and tachycardia. Echocardiography will give you the diagnosis, structural changes, but not give the etiology. Cardiac catheterization is indicated to exclude ischemic heart disease in these patients. Is obligatory in the diagnostic algorithm, especially if the patient has some compliance. Also, CT coronarography may give that information. MRI is other method which will give the very, very important information of the structural changes, and it's not with contrast, and especially in the patient who have renal insufficiency are a good method for diagnosis. From the physical exam, symptoms due to decreased cardiac output, low blood pressure, tachycardia, areas, pleural infusions, from the cardiac status, maybe have laterally displaced apex of the myocardium, different degree of murmur of mitral regurgitation. If you remember from the valve disease, relative or functional mitral regurgitation, one have dilatation of the ring of the mitral valve, and maybe have tricuspidal regurgitation, also due to secondary to pulmonary hypertension, distended neck veins, hepatomegaly, maybe have fasciitis and peripheral edema, different different degree. Symptoms may be from months, maybe from the day acute beginning, if have tachycardia, and also can have gallop heart sounds, which is the third sound due to left ventricular dysfunction, and also can be heard easily if the wall is the thorax wall can be very thin, and the auscultation is better. So the treatment, the diagnosis is very important, because can stop progression of the progression of the disease, can improve symptomatic, and receive stabilization. Sudden cardiac death is most often a reason. Systemic embolization, alcohol must be stopped, not decrease the amount, and must in this patient discuss the therapy, because they have different need of diuretic, maybe have resistance in the very progressive disease, and maybe have need infusion of sympathicomimetics, of infusion of diuretic to improve their balance and diuresis. As of course, salt restriction, fluid restriction in this patient, they are not with renal insufficiency, and must take enough to have good electrolyte water balance. The rule is what have they taken as water. The diuresis is the same to have negative balance, because if they have not take enough amount of water and liquids, they will be have a negative balance. So the treatment, of course, will be from with drugs, and all drugs who are used in the standard therapy of the heart failure. ACE inhibitors also, and all the drugs who as vasodilatator, who improve prognosis of the patient with heart failure, suppress ventricle remodeling, taking improvement in the endothelial dysfunction, and reduce cardiovascular mortality. Amiodarone is the drug of choice from the antiarrhythmic, who have no no cardiodepressive effect, as you know, proper phenone are contraindicated in the patient with acute myocardial infarction with low ejection fraction, because every antiarrhythmic except beta blockers have pro-arrhythmic effect, and they induce also ventricular disturbances, and maybe lead to sudden death. That's why, as the patients taking amiodarone, looking for prolongation of the QT interval, of the weakness of QRS complex, because that may be due to their pro-arrhythmic effect and giving increased risk of sudden death. So beta blockers are the drugs who improve the prognosis, and in the previous years the beta blockers was forbidden for patients over 60 years, because it's thinking that they have no receptors for beta blockers, and they are cannot acting. But early in the 80 years, when the results of the big studies come, in nowadays beta blockers are taken, and from 80 or 40 years, even 90 old years patients, because they have down regulations in the heart failure, and it's increased density of the beta receptors, and it needs some time to beta blockers to begin to act and to show their favorable effect. But ACE inhibitors and beta blockers must give in titration dose, because if the patient is hypotonic, and must increase slowly the dose, but begin with half tablet and on the 2 to 3 days to increase the dose according his blood pressure, according his heart rate. Of course, the diuretics are some groups. Furosemide or Lasix or Thorazine are diuretics which are acting on handle whoop, spironolactone, or other eplerenone are potassium sparing diuretics. The digoxin is other drug which may be better from pharmacology, but the digoxin not improve the prognosis. It can improve physical activity, but it's giving only in the patient who is in atrial fibrillation to control the heart rate, in combination with beta blockers, because they increase the risk of sudden death, because their therapeutic window is very small, and risk of digoxin toxicity and can give the opportunity for fatal arrhythmia, ventricular for the sudden cardiac death. Also, in the patient with atrial fibrillation, anticoagulation is absolutely indicated. In the patient with dilated cardiomyopathy and with risk for sudden death is nowadays is implanted cardiac defibrillator. Biventricular pacemaker is indicated in patients who have white QRS complex, and here is the difference from the other pacemaker, because they are some types VVI pacemakers with one electrode who stimulate and control the heart rate. In the biventricular pacemaker, we have one electrode in right and one electrode in left ventricle, because as in left bundle branch block or for right bundle branch block, it is which have according definition widening more than 0.0 milliseconds wide the QRS complex, and in this the contraction here, this is not AV block. Here we have no coordinated contraction of the left ventricle, and in this patient, as put on the biventricle pacemaker who are with dilated cardiomyopathy, that improve and mitral insufficiency because it improve the synchronization of the contraction of the different part of the left ventricle, and so can decrease in the mitral insufficiency, can increase the ejection fraction, but no all patients react with that improvement, only 30%, and that is the question. But in nowadays, a lot of biventricular pacemaker is implanted in the patient with left ventricle dysfunction to improve their optimal drug therapy and their prognosis. And the cardiac transplantation is the late step in the treatment of these patients, and also in patients with a high degree mitral insufficiency is making all operative left ventricle reshaping plastic of the mitral valve to decrease the mitral insufficiency if you have indication in combination with operative or coronary bypass operation to improve it and to remain the size of the left ventricle. We have talked about different forms. First of all, cardiomyopathy, individuals who take more than 90 grams, and also we have talked that every have different activity of alcohol dehydrogenase, and may be present with heart failure after many years. Peripartum cardiomyopathy during last trimester or within 6 months after delivery, symptoms of heart failure, typically most often in multipares, older pregnant women. These are with twins, and they have the symptoms of heart failure. In the neuromuscular disease, Duchenne also can have other symptoms of the progressive muscular dystrophy with mutation in gene encoding cardiac structure protein. On ACG, maybe have different rhythm disturbances and rapidly progressive heart failure. Some cardiomyopathy received after some cardiotoxic chemotherapeutic, especially in nowadays a lot of chemotherapeutics, and in all patients according protocol before starting chemotherapy and after receiving these all patients just will stop and will continue after 2 minutes. Кажете, доктор Гатен. Сутрин мога да дойда или от Сузаран да дойде в 8 или 9. Айде утре в 9, защото сега ще се измервани вече. Превеждаме от нефрологията и това. Но аз ти се чудим за тия изследвания. Както тя разбирам, те, но да си спокойни за това направо. Да, и след това те ще си призпишат, защото ти си може чакат резултат. Науката напредва. Ма така си е. И всеки това е. Rachel. Sorry for this time. And especially the adriamycin is the old chemotherapeutic agent who give left ventricle dysfunction. These patients with non-Hodgkin lymphomes with Hodgkin lymphomes are controlled echocardiography to see is there decreasement of their ejection fraction. Toxicity may begin after 3 months, maybe begin after first dose. So must think about that drug induced cardiomyopathy. Other drugs which include maybe herceptin, as you know, in the carcinomes of the glandular mama is used. High dose diclofosfamide, imatinib, and of course in the patients with cocaine abuse also maybe have dilated cardiomyopathy, and they maybe have a really intact coronary artery, but on the form of the vasoconstriction, they may receive even ACG of the myocardial infarction with test elevation, may have tachycardia, which also induced changes and dilated cardiomyopathy. Other form is arrhythmogenic right ventricle cardiomyopathy, which is familial cardiomyopathy, autosomal dominant, where have fibrofatty tissue replacement of the normal myocardial tissue in the right ventricle, in less degree of the left ventricle myocardium, and they have a ryanodine receptor chain mutation who may be proved in genetic tests, and these tests are very expensive, not performing in every laboratory in every country. Typical is the ACG, where have QRS prolongation in right precordial leads with form of the left bundle branch block and giving also ventricular tachycardia. The diagnosis can be made on MRI or CT. In nowadays, these methods give a lot of structural information about the structural changes. On the echo, can see right ventricle dilatation and also fibrofatty deposition and aneurysm. And in this patient, the risk of sudden death is very big, so they are candidate for implantated cardio defibrillator or cardiac transplantation. Some other form interesting is TAKO-TSUBO cardiomyopathy or stress, and as you see here on the picture, on this picture on the left ventricle is a specially form of the left ventricle of the left ventricle apex as octopole, and that's why is the name TAKO-TSUBO. Also known is apical ballooning syndrome, and in these patients also can have ACG as the elevation and elevation of the troponin markers with low ejection fraction, but on coronarography, the coronary artery are normal, and in this patient, this left ventricle dysfunction is temporary, and it may be with very good prognosis and reversible of these changes. And left ventricle non-compaction is also inheritance, and there is preserved embryonal structure with echo picture of the processus sinuitis in the myocardium that characterize typically embryonic heart on echo, multiple deep tuberculation of the myocardium, and the treatment is treatment of the heart failure. The other form, the hypertrophic cardiomyopathy, where the typical is left ventricle hypertrophy, non-dilated chamber, no data for wall ejection fraction, and this hypertrophy is not due to hypertension, is not due to aortic stenosis, and this hypertrophy may be asymmetric hypertrophy with preferred hypertrophy of the interventricular septum, and it can give this asymmetric hypertrophy dynamic left fall, left ventricle outflow tract pressure gradient, interventricular gradient, and especially in tachycardia. You can imagine this hypertrophic myocardium is very closely and the decrease the opening and the filling, and there is interventricular gradient, and these patients maybe have syncopes during physical activity, where when the heart rate is normally increase during physical activity, may have syncopal symptomatic and may receive and sudden cardiac death. Of course, different genetic abnormalities, but the main type is autosomic dominant, very a lot of mutations, more than 400, as you see, in 13 cardiac sarcomeres. We cannot identify all of them. That's why I must talk of the patient, in young patients to 15 years old, in very different diagnosis with the sport heart, because the sport, stranger sport who are on competition runners can have also hypertrophy, and the difference is that as the sportsmen stop the physical activity, this hypertrophy decrease and disappearance, and they have normal function. But in hypertrophic cardiomyopathy, no changes, and the hypertrophy may be even 30 millimeters, and you can imagine what a big size is this hypertrophy. Here is one septum with a big hypertrophy, a massive left ventricle hypertrophy. Here is also a normal heart. Here you can see also of the O, and histopathology have significant myofiber disarrangement and intestinal fibrosis. So the You can imagine that even on the echocardiography, on computer tomography, that changes in the wall and must diagnose and take correct treatment. The hypertrophic cardiomyopathy is the a real instance for diastolic dysfunction, but it may be have also this hypertrophy to suppress the myocardial vessels and to give myocardial ischemia, which can lead in end-stage and systolic dysfunction. May have, as every hypertrophy, a risk for sudden cardiac death, and of course, the reason for diastolic heart failure. So variants may be independent of the location of the hypertrophy, subaortic, septal, or and anterior wall. Maybe have asymmetric hypertrophy, septum and anterior wall. Maybe have only basal septal hypertrophy. As you see, these percents decrease, concentric hypertrophy, symmetric hypertrophy, or other apical hypertrophy, or as no Japan type cardiomyopathy, and these patients have negative T waves on the ACG from V2 to V4 leads, and even these patients have coronarography for acute coronary syndromes, and if they know that, must say, because every doctor will say to him, you have acute coronary syndromes, and that's why the diagnosis and is very important. Here you can see symmetric hypertrophy, the same thickness of the septum of the anterior wall of the left ventricle. But here you can see apical hypertrophy. We have a normal or even small left ventricle cavity, but you can see how thick is the septum. The normal size of the septum thickness is 10 to 11 millimeters, and as I say you here, is more than 15 than 20 millimeters. And in every so hypertrophy, if the patient has no history for hypertension, for other reason for hypertrophy, you must think about hypertrophic cardiomyopathy. Here is also asymmetric, which is on subaortal, and this type of hypertrophy can give intraventricular gradient, because can give also a mitral regurgitation, and the septum is against the atrial valve, and giving difficulty of feeling of the left ventricle, and also a systolic anterior modern of the mitral valve, or so known the systolic anterior moving of the mitral valve, which is have typical auscultation, so must looking on the echocardiography. This is the main abnormality in the hypertrophic cardiomyopathy. Thickening usually begins during early adolescence and until 16 years can finish, and it's uncommon to thickening progress after this age, and so these patients especially must control regularly every year about rhythm disturbances, about progression of the left ventricle function. The hypertrophy is usually greatest in the septum, but the muscle thickening may be not enough to narrow the outflow tract, and maybe have no gradient, but also can give an obstruction of the flow of blood out of the heart into the aorta if the thickness is very big, and especially when it's asymmetric and giving obstruction, because in some cases it touches the septum and blocking the outflow tract, and also can give and mitral regurgitation, and this gradient may be dynamic. It may be not seen on normal rest condition, but it may be provoked, and maybe see outflow tract under a gradient more than 50 millimeters, so when have a hypertrophic obstructive cardiomyopathy with the picture of diastolic dysfunction, impaired diastolic filling, increased filling pressure, and diastolic pressure in the left ventricle with mitral regurgitation and different forms of arrhythmia. And this gradient may be increased with all drugs and methods, so it's decreased pre-wall, different maneuvers that decrease and diastolic volume, also dehydration, Valsalva methods, immune nitrate, and exercise who will give increasement of the murmur of SAM or hypertrophic cardiomyopathy. You can see here the gradient in rest is 1, and after Valsalva or immune nitrate, which decrease as vasodilatator pre-wall, increase the gradient. And most of the patients have not so big gradient, no, but it may be increased even to 200 millimeters, and in nowadays different methods of treatment, and one of them is induced also as alcohol embolization of the coronary artery that that maintain the blood flow of this part of the septum as you induce the myocardial infarction, and that decrease the hypertrophy and decrease the gradient, and also with that effect maybe decrease the compliance of the patient. In severe gradient, patient may have dyspnea, chest pain, syncope, and all risk of sudden death of different atrial arrhythmia. So the clinical feature may be asymptomatic with echocardiography findings only, and may be symptomatic with complaints of dyspnea, of angina, of fatigue or pressing up, and increased risk of sudden cardiac different atrial fibrillation, palpitation, and symptoms of heart failure. The different symptoms and presentations are according angina, syncope, and dyspnea, risk of sudden death, and absolutely asymptomatic clinical picture. And the diagnosis is on ACG data for hypertrophy, but maybe not typical if have hypertension. On echocardiography, left ventricle hypertrophy, maybe have on ACG giant T-wave inversion, abnormal QRS complex, left bundle branch block, data for left atrial enlargement and different ventricle arrhythmia. And it usually begins between 5 to 15 years in age, and in this age is recommended to 20 years every year echo control, and also must looking in these patients if have abnormality on ACG for echo exam. So the clinical course depends from the adverse clinical events, sudden cardiac death, embolic stroke, and of course different rhythm disturbances, dyspnea, angina, syncope. Presyncope, syncope may be during physical activity, maybe during rest, of course, and it may be with increased gradient, with low cardiac output, with hypoperfusion, with hypotonia, maybe due syncope to rhythm disturbances, and the risk of sudden death is higher in children who have progressive hypertrophy, and in the athletes, as you see, the high percent risk of death in athletes. That's why the sportsmen are looking every checkup year for stress tests, for Holter ACG, for echocardiography, and if they have so episode, they are stopped from activity, physical sport, and poor prognosis in males, young age of onset, family history for sudden death in the family on young age, history for syncope, and exercise-induced hypotonia, which may be due to progressive dynamic gradient during physical activity. And risk factors, can you see, are malignant family history for sudden death, episode of sudden cardiac death, sustained ventricular tachycardia or supraventricular tachycardia on Holter ACG, atrial fibrillation, dilated left ventricle, period of syncope, and severe hypertrophy, more than 13 millimeters, and abnormal blood pressure response to exercise. And so the recommendation for the athletes are to participated in athletic activity if absent ventricle tachycardia on Holter, family history of sudden death, history of syncope, severe hemodynamic abnormalities or gradient intraventricular more than 50 millimeter, exercise-induced hypotonia, enlarged left atrium, which may be due to atrial fibrillation, and abnormal myocardial perfusion. Management must avoid dehydration and some drugs because the digoxin and hypertrophy, the risk of sudden death increase, vasodilatators to increase risk of syncope, and dehydropyridines or calcium antagonists and diuretics, drug of choice, are better adrenergic blockers to receive beta blockades, receive frequency of heart rate to 60, and also if they contraindication, calcium channel blockers, but of the type of the verapamil and DOTSM, no amlodipine, which will acting as vasodilators, antiarrhythmic, and of course amiodarone, and pacemakers. Pacemakers may control the rhythm, may control, improve the contraction of the hypertrophy myocardiomyopathy, but it is open heart operation with resection of the septum, and this is alcohol septal ablation procedure when induced controlled myocardial infarction through septal perforator perfusing basal septum, and that will lead to water thinning and decreasing gradient. And another form is hypertrophic or hypertensive cardiomyopathy of the elderly, where you see that the hypertrophy is not so heavy thickness, under 22 millimeters, small left ventricle cavity, and have history of hypertension and often other atherosclerotic disease. Some other diseases with hypertrophic cardiomyopathy are Danon disease with enlarged ventricle myocytes with serious arrhythmia, left ventricle hypertrophy on the ACG, also genetic disease, Friedreich ataxia, Wernicke neurology, degenerative disease with disturbances of some proteins of taking part in mitochondrial iron metabolism, and also heart is included with the typical signs, some glycogen storage, and as talk about Fabry disease, autosomal recessive disorders with deficit of lysosomal alpha galactinases, and nowadays this disease is treated. The patient can receive replacement therapy if the disease is early diagnosed and have no accumulation of phospholipids of the heart, which lead to ventricular hypertrophy, and that's why in young people with family history for renal disease with hypertrophy on the ACG, on the echo, is performing screening for these Higgs-linked autosomal disease. The restrictive cardiomyopathy is other very rarely form we have also abnormal diastolic function with impaired ventricular filling, with very often making differential diagnosis with constrictive pericarditis, and very often, but in some areas of the world, may be a reason for that in Africa, India, South America, because the high incidence of the endomyocardial fibrosis Chagas disease, and maybe due idiopathic form or in some secondary forms, as in scleroderma, from the infiltrative disease, amyloidosis, sarcoidosis, some neurologic disease from the storage disease is the hemochromatosis, and hemochromatosis secondary, in which disease in thalassemia major, and in these patients have from the many blood transfusions, load of iron in the heart, in the liver, and if they not take their drug therapy, and they receive very heavy heart failure and rhythm disturbances from the type of restrictive cardiomyopathy. Other form may be carcinoid, rare disease, metastatic malignancy, and especially radiation and some anthracycline chemotherapeutic. The clinical manifestation is the symptoms of right and left heart failure. Jugular venous pulse is elevated, and echo can give us data for diastolic dysfunction, not so great systolic dysfunction, and different patterns of diastolic dysfunction with increase of feeling pressure. So you see that it's not so because in hypertrophic cardiomyopathy, the wall thickness, the diastolic volumes are increased, but not so as in dilated cardiomyopathy, and low ejection fraction is not so. It is nearly 45 between mid-range, and must looking for the reason, biopsy, of course, and the in etiology aspect, mediastinal radiation, cardiac surgery, perform different imaging methods, investigation as MRI, computer tomography, coronarography to exclude it, coronary disease, and one multidisciplinary working for the different reasons. No satisfactory medical therapy, diuretics for extremely high filling pressure, chronic anticoagulation because have risk of embolic incidents, therapy with vasodilatators, and control of rhythm disturbances. Eosinophilic endomyocardial disease, also Loeffler endocarditis, and different toxic effect of eosinophil proteins. The treatment is with glucocorticosteroids, with diuretics, vasodilators, anticoagulants, ones, and surgical resection of fibrotic tissue. Cardiac amyloidosis may be primary, may be secondary due to chronic infection. Also can give diastolic dysfunction and very typical whitening on the septum and also myocardium, typical speckled appearance, and maybe proof with biopsy from gingiva or from gastrointestinal tract biopsy, where can see on a microscope the amyloid deposition. Other restrictive form are in sarcoidosis, often giving us AV block and rhythm disturbances and some pulmonary distortion in the test. Myocarditis, as you know, difficult diagnosis, inflammatory disease of the myocardium, and the reason for the sudden death, the reason for the dilated cardiomyopathy. So must thinking about that disease, especially for in the patients with history for viral disease. Viruses are most frequent pathogens, most frequently with enterovirus, Coxsackie virus, parvovirus, human herpes virus, and all grip virus, but the infection may be very wide. It can finish to 1 week, but as it started one autoimmune response, and it depends from the this autoimmune response of the host. It can start it one clinical picture of dilated cardiomyopathy, one viral myocarditis, maybe finish with full recovery, maybe fulminant with sudden death, and maybe a reason for chronic heart failure. Myocardial damage may be due to, as talk about different drugs and chemotherapeutics, some toxins as cocaine, some parasites as Chagas disease, toxoplasmosis, and so. As you see, the reason are what bacterial, but in connection with other bacterial infection in the body, especially as in pneumonia, as in abscess, pulmonary or esophagus, some fungal infection, parasitic infection from the viral agents you can see on the first place, Coxsackie, some immunorelated myocarditis, allergens in tetanus, in different vaccines, drugs, penicillin, cohitin also given, and lidocaine, tetracycline, different but very, very rare cases, and also some chemotherapeutic agents, heavy metals, and some hormones. So 15 to 20% of the myocarditis are enteroviruses, and in a lot of percents the exact viral agent is not cannot prove, and must investigate it for all different viral agents or viral panels as used to send to microbiology and laboratory. So acute viral myocarditis may be given first of all Coxsackie A and B, echoviruses, influenza, less common adenovirus, arbovirus, Epstein-Barr virus, also meals, rubella virus, varicella, zoster viruses. But the time course of viral myocarditis in the time of viremia, in the time of viral infections, or soon after a viral infection, it the viral agent induced autoimmune response with the activation of the all cytokine factors and expression, and it all depends from the recovery of that process, giving to myocyte necrosis, degree of infiltrating mononuclear cells with activity of the immune response of the host, and maybe viral clearing and full recovery, and maybe enough not viral cleaning in the first days, and after that receiving fibrosis, cardiac dilatation, and fibrotic tissue with no lymphocyte infiltrate. The diagnosis on the biopsy is according to Dallas criteria for a lot of time. And so the pathophysiology of the myocarditis from one side depends from the viral infection, from the effect on the immune response with giving fibrosis in the end stage with inflammation and decreased myocardial contractility, increased left ventricle sizes with symptoms of chronic heart failure with risk for sudden cardiac death, different arrhythmia, different degree of pulmonary congestion. So the clinical presentation may be vary from asymptomatic acute viral infection, even the person not know that have infection, and after that have dilated cardiomyopathy very often as idiopathic, but the most often reason for this idiopathic cardiomyopathy dilated or the viral infections, and it may be fulminant myocarditis, asymptomatic with recovery of the function of the left ventricle, and chronic myocarditis with the picture of the dilative cardiomyopathy, or the presentation with heart failure with chronic dilated cardiomyopathy and different arrhythmia and risk for sudden death. Spectrum of the clinical presentation may be excessive fatigue, chest pain, unexplained sinus tachycardia, maybe have combination of with pericarditis, gallop rhythm, abnormal cardiogram with left bundle branch walk, with sinus tachycardia, with ventricle extrovert, and also abnormal echocardiography with dilated cavity of the left ventricle, hyperkinesia, and wall ejection, a fraction from the clinical picture of the different degree of heart failure. So the clinical pictures may be very, very varied, from mild symptoms of chest pain and also transitory ACG changes, which may mimic even myocardial infarction. And every myocardial disease will give can give erasement of creatinine, phosphokinases of troponin, and the differential diagnosis of acute coronary syndrome. And these patients can have indication for coronarography, also for computer tomography and MRI diagnosis, and chest pain may be very different in one acute myocardial infarction. Chronic heart failure must have history for all diseases, especially on the first place ischemic heart disease. Some arrhythmia also Holter ACG favor maybe have also in the end of the viral infections. Diagnosis is complex with ACG, no specific wave of abnormalities, increasement of creatinine, phosphokinases, and troponin. Chest X-ray can give from normal shadow to cardiomegaly, echocardiography, and the most important investigations, cardiovascular magnetic resonance, can also repeated sensitive non-invasive diagnostic test and endomyocardial biopsy, giving the definitive diagnosis and can be giving the structural changes due from other side also investigated for different virus genomes as phenotypization in nowadays from the biomarkers. Of course, inflammatory markers may be normal if the viral infection was previous years or months and now presents with the picture of heart failure, but they are often elevated. CRP or also markers for viral etiology. Cardiac troponins, as you know, are the very more specific cardiac injury markers, and in suspicion of myocarditis must investigated, but the normal value not excluded the myocarditis. ACG may be giving different changes from sinus tachycardia, diffuse T-wave, QRS, QT prolongation, and also the most often sinus tachycardia, T-wave, non-specific STD changes maybe mimic acute myocardial infarction, maybe have ST depression, T-wave inversion, or even that as previous myocardial infarction from the fibrosed tissue on the X-ray, giving cardiomegaly. You can see here with with pulmonary congestion, as you see here the enlarged cases and here the Kelly be but this shadow giving enlargement of the left ventricle, apex pulmonary artery prominent, and the big size. Echocardiography also give very often inductive cardiopathy, one around form of the left ventricle with diffuse hypokinesia. So now is not moving. Different forms of regional motion. Also, if the patient have acute and recovery with fibrosis and low ejection fraction. In the acute myocarditis, after 4 to 6 weeks maybe recovery and normalize the ejection fraction, and so these patients have good prognosis. Here you can see the diagnosis of the diagnosis with MRI magnetic resonance, where you can see here some edema of the ventricle. Very often changes are in the inferior wall, and after repeat the diagnosis in the next week, it can be recovered and decreased the thickness and normalize the ejection fraction. The endomyocardial biopsy is the gold standard, where is looking the inflammatory infiltrates, lymphocyte infiltrates association with myocyte degeneration and necrosis, and if you have no lymphocyte infiltrates or predominate fibrosis tissue, this is one chronic myocarditis with fibrosis. So the diagnosis is making with combination of clinical presentation, history for viral infection, echocardiography, laboratory tests, ACG, who can give rhythm disturbances as the changes. The treatment is in first 2 to 4 weeks of treatment of the heart failure, treatment of the rhythm disturbances, and optimal treatment with all drugs and not so have heavy physical activity, sports in these days, and weeks if you have typical typical viral agent, maybe discuss interferon in nowadays, may discuss cohitin or immunomodulating, even if the reaction of the replication is so good, prominent, maybe giving and immunosuppression, and after that, if no effect and have low ejection fraction, young people can discuss even cardiac transplantation. Have you any questions?
No.
No? Good. For tomorrow, we'll